Morning. Yeah.
Thank you for this invitation. I'm just getting out of bed here. It's early here, but I'm all set up. Whenever I have my slides, I can screen share whenever it's time.
So we are live.
Okay, we are live.
Good evening. Welcome to iFocus lecture 140. We have glaucoma sessions continuing, but we have international masterclasses starting today. And to start off, we have a great personality and world-renowned glaucoma specialist, Professor Kuldev Singh from Stanford University, USA. Vanita will introduce him.
Thank you so much. Indeed, it is great pride and with pleasure that we, Team CFS, is honored to have Professor Kuldev Singh, Director of Glaucoma, as well as Professor of Ophthalmology at Stanford. He completed his medical education at Johns Hopkins. He got his MPH from Johns Hopkins and also did a fellowship at Johns Hopkins in 1987, but went on to do another one at Bascom Palmer. He got certified by the board in 1992, following which he joined Stanford as faculty in the same year. And in 2003, he rose to the rank of professor. He has published extensively, over 200 original peer-reviewed articles, and delivered over 350 invited lectures, including 70 named keynote or visiting professorships. He has edited 3 textbooks and served on the editorial board of 11 ophthalmic publications. His current academic interests include glaucoma and cataract surgery, the epidemiology of myopia and glaucoma, as well as ophthalmic genetics, as also healthcare delivery in underserved communities in the United States, as well as overseas. He is an investigator in the National Institutes of Health funded by the NEI, as well as he's funded by the US Food and Drug Administration, the FDA, that is, to study patient-related outcomes with minimally invasive glaucoma surgery. Coincidentally, he's also a standing member of the FDA Advisory Committee on Ophthalmic Devices, continues in that position, as well as being a consultant to the FDA. He has numerous awards and honors to his name, and I will name just a few. His life, he received the Life Achievement Honor Award by the American Academy of Ophthalmology in 2015, and prior to that, in 2005, he received the Senior Achievement Award by the American Academy of Ophthalmology. He received a prestigious Delta Omega Honor Society at the Johns Hopkins Bloomberg School of Public Health, as well as the Founders Award by the World Glaucoma Association. And proudly also as Asian American faculty at Stanford University in 2012. He also holds I think the reputation of being the best doctor in a list of best doctors in America from 1996 to present, if I have understood correctly. And a global nomination-based survey conducted in 2018 by the Ophthalmologist magazine ranked Dr. Singh as one of the 15 most influential individuals in ophthalmology worldwide. He has held several leadership positions, which include President of the American Glaucoma Society, 2013 to 15, Chair, Board of Directors, Glaucoma Research Foundation, 2009 to 2011, Executive Vice President of the World Glaucoma Association, 2008 to 2012, and Board of Governors of the World Glaucoma Association, 2007 to 2017. With these words, we invite Professor Kuldev Singh to deliver his talk today on strategies in the new millennium, about strategies related to glaucoma care.
Thank you, Vanita, for that overly kind introduction. It's amazing how the years fly by, and you go from being what I consider a young person to suddenly one of the old people, and they start giving you awards for longevity. And you know, for most importantly, I hope everybody is safe. And you know, I have so much family in India, scattered really all throughout the country, and I worry about them. I know it's been a tough year. Everyone has been impacted. I mean, nobody has escaped the scourge of the pandemic, and we certainly have had our share of problems here. But in India, I know, you know, we every night we go to sleep just hoping and praying that everybody's okay. And I look forward to the day we can meet in person. But fortunately, with Zoom and all the, you know, whenever you have a crisis like this, people find a way to make, you know, discover ways for people to still stay in touch. And this is quite amazing that we can remotely be doing this. I mean, we weren't doing this before the pandemic, so this is one of the few, very few positives that I think have come out of this. Mostly it's been a tragedy. So anyway, I'm going to share. Let me share my screen. I don't. Let's do this here. Hmm. You see my screen or no? Not yet, huh?
Not yet.
What is it?
Here we go. Let's see if we can do this. Here we go.
Yeah.
Do you see it now?
Yes.
It says you have started your screen share. Yeah.
Yeah, it's there.
Good.
It's there. Is it okay?
Yeah.
Perfect.
All right. So the talk I will give, let me make sure I have a clock here in front of me because I want to leave a few minutes for questions. It's really like a philosophical talk, millennial glaucoma care. And I've added a second piece, and that is why trabeculectomy must survive in the era of MIGS. You know, after watching Zoom lectures for a year, I think people are a bit burnt out on Zoom, but I hope I'll at least try to make this talk somewhat entertaining and perhaps a bit provocative for the sake of keeping people's interest and maybe have some good discussion in the time that we may have available. These are my disclosures. So I do a lot of consulting for companies, mostly advisory board participation. Many of these are just a once a year meeting. These days, a once a year Zoom meeting. As Vinita mentioned, I do receive support from the U.S. Food and Drug Administration and the National Eye Institute. I've also received funds from the National Space Biomedical Research Institute, which is the arm of the research arm of NASA, which it looks at space travel and other things. And then Research to Prevent Blindness supports our core work at our university. So, you know, when I went into glaucoma, glaucoma was considered kind of a B profession, you know, back in the day, because not a lot had been happening in glaucoma for the past 50 years when I started. And I think these days glaucoma is considered really one of the most desirable specialties. And there's a reason why this has happened. We have seen a big uptick in the number of applications for glaucoma fellowships. Our glaucoma practitioners are thriving. They're you know, in fact, in leadership positions in the U.S., you know, there's a disproportionately large number of people in glaucoma relative to the other subspecialties. And so glaucoma is, you know, in the midst of a renaissance, and this has come about because of advances in perimetry and imaging, new drugs that were introduced starting in the 90s that were really double the number of options, or more than double the number of options that we have to pharmacologically treat glaucoma. I think the evolution of modern cataract surgery into a glaucoma procedure, and then the novel surgical procedures that can often be added on to cataract surgery, but also the new procedures that are done as standalone procedures, have all really played a role in making glaucoma you know, a field that is very, very attractive. And I'm delighted that I chose this field. So I'll go fairly quickly. This is some early work from Tom Zimmerman challenging trabeculectomy, and this is a non-penetrating trabeculectomy. We would call this a deep sclerectomy now. I trace this back to the beginning of the so-called MIGS, or the less invasive glaucoma surgical options that we have today, that have led to a series of injectable or implantable devices that are used in the U.S. And I just have to point out that I'm giving kind of a U.S. perspective here. You know, I'd love to learn from you, from everyone else on how, what's being done in India. I know that I have a really high regard for medical care in India. I think the doctors are phenomenal. The resources are there, but obviously there's a lot of unmet need just because of the population that needs to be served. And even with this really strong medical community, there's always challenges just because the sheer numbers of people that have to be treated. But I'd love to hear others. We'll have some time for discussion. These are some of the stents that are available in the U.S., including one, the CyPass, which was a suprachoroidal device that was removed from the market because of corneal problems. We have a blood forming procedure known as Zen that's approved in the US. And then we have another one that's not approved in the US, but is available in Europe and some other parts of the world, known as a PreserFlow, which is kind of an exciting device that we hope will be approved. So, when I trained in the 80s, we had, maybe 3 or 4 things we could do if eye drops didn't work. Nowadays, there's so many different options, and most of the advances have occurred in increasing and enhancing outflow through the conventional pathway, through the trabecular meshwork, Schlemm's canal pathway, and there are implantable procedures as well as goniotomy type procedures. But we've also had some developments in development of new drainage systems, and as well as in laser procedures. So there are many, many more options available. And when you have more options, you have more practice patterns that emerge. This is actually an interesting slide showing the growth of the ophthalmology business. This is a global growth in ophthalmology business. And the average growth of the ophthalmology business is about 6% per year globally. And this is projected growth until 2022. And you can see how glaucoma device is outpacing everything else. It's a far and away the fastest growing market. Of course, it started with a very low number. So obviously the numbers are nowhere near cataract, IOL, and refractive. But if you look at the actual growth, it's much faster than any other area of ophthalmology. So MIGS has really been part of this revolution. MIGS was initially described as microincisional glaucoma surgery. Many now refer to it as minimally invasive glaucoma surgery. What I don't think we want it to become is millennial glaucoma surgery. And this is where I hope this remainder of this lecture is at least somewhat entertaining. The millennials are a demographic cohort between the Gen X baby boomers and Gen Z, also known as Gen Y or echo boomers. These are people born between 1981 and 1996. So right now, I'll just say first and foremost that if you were born in this period, I'm not necessarily talking about you, because to me, millennial is a way of thinking. It's not a year you were born. I know many people born in this era that act like they're old school glaucoma doctors. There are others who are 70 years old who practice like millennials. It's a way of thinking, not an age. But one thing that millennials have in common is that the primary focus is on themselves. This has been highlighted, the fact that this is a generation that feels that they're important, and many of them are brilliant, and they probably are important. But I think this has impacted medical care, and I will share, my impressions of what I see around me, and hopefully, some of this will be relevant to India and other parts of the world. Maybe it isn't. I don't know this, but it'll be good to hear back. But anyway, just to point out again, this is the demographic, but not a demographic. Millennial is not a demographic, but a way of thinking. To me, the millennial glaucoma doctor in the United States generally has 7 titles. They have many, many titles. When you go to meetings and you ask them what they would do for a patient, when you present a patient, the only words you hear out of their mouth are me, my, myself, and I. So common things would be, in my hands, this is my best procedure. And I don't like to do this other procedure because the reimbursement is not high enough for this, or this is too much work for me to, the focus is really on the doctor and not the patient. So you rarely will be at a meeting where someone will say, I will do what's in the best interest of the patient. That used to be always sort of a given in the generation where I trained, but nowadays it's more like what can I get out of this? And unfortunately, this has kind of had somewhat of a negative impact on care. But before I go too far in criticizing millennials, I want to say that the prior generation, of which I'm a part, it was actually worse. And this is what I call the era of Aegis, the Advanced Glaucoma Intervention Study, because this is what preceded Millennials. And this was driven by a series of randomized clinical trials that led people to believe they knew everything that needed to be known about glaucoma. And Aegis is kind of a representative example of these trials. This is a trial that compared laser trabeculoplasty with the trabeculectomy in patients who had failed medical therapy. And this was a study question, and the study question answer was that laser lowers pressure less effectively than surgery. Surgery is more effective in lowering pressure and in preserving visual function. But this large data set from the study was allowed an opportunity for many post hoc analyses, and one such analysis was the associative analysis, where patients who got laser first or surgery first were merged into one group, one large group. And so they no longer had the benefit of randomization and divided based on the proportion of visits that their pressure was under 18 millimeters of mercury. And for those whose pressure was always under 18, when you looked at the visual field score here from 0 to 4, actually 0 to 3 is where most of this is happening, on the y-axis, it looked like the group that was always under 18 showing no progression. But this was unfortunately led to the belief that if your pressure got to 12.3, glaucoma would stabilize and it wouldn't get worse. And of course, this line right here doesn't represent everyone whose pressure is 12.3 or less over an 8-year period, but rather it's the average of the individual averages. So some patients may have had an average of 15 or 16, others may have had an average of 5 or 6, especially if they'd had surgery and had very low pressures. And the 12 was the average of the 16s and the 12s and the 5s and all the others. And so unfortunately, this led to a more aggressive approach to treat glaucoma, and many people probably got more aggressive treatment than they needed. Not everyone needs to be at 12, and some of the patients who are at 12 are not low enough and keep getting worse. It's also important to keep in mind that this line represents averages. Some patients may have had their visual field improve a little bit. Others may have had it worsen, but this is the average field. And there are a subset of patients in this group that got worse. But unfortunately, this sort of dose-response relationship between IOP and glaucoma progression created this exaggeration of the importance of absolute target pressures or pressure goals that really misrepresented the glaucoma practice, and led to this common practice that has persisted to this day. If IOP is above target, the patient's glaucoma will get worse. The goal is to lower IOP below target to stabilize the disease. And this binary type of approach allows the patient visits with doctors to be very short, because the doctor can say, yes, your pressure is okay. It's below the number I have set for you. You go home, come back in 4 months, or it's above the number, you need more treatment. This is an interesting work that we've been involved in. This is a collaboration with Malvina Edelman, who's the head of the device section of FDA, George Spaeth and others. Most of the work here was done by Tianjing Li and Jimmy Lee at Johns Hopkins, and they've since moved on. But Tianjing and Jimmy did a patient preference survey. This was funded by the FDA, where they asked patients, what's most important to you? What are the most important, and this is based on one-on-one interviews, and rankings are based on this preference solicitation survey. It turns out that when you ask patients what's most important to them, more important than maintaining mobility or driving a car or reading in dim light or bright light is having control of the intraocular pressure.
इलेक्ट्रिसिटी वाला भी सही रहेगा मुझे लगा।
So anyway, I think we're getting, someone should be muted here.
Edwin, can you mute them?
इलेक्ट्रिसिटी वाले में है खेल रही है मोमेंट।
Anyway, it's okay. I can keep going. I'll just speak louder. But yeah, we sometimes lose
Can you ask the
electricity here
Edwin to
also. So it's anyway. What was interesting was the focus here was the control on intraocular pressure. they were more focused on their pressure being controlled. This was more important to them than any other criteria, such as being able to read or
जॉब
drive
ऐसी
a
चीज
car.
है ना आदमी
Surprising.
देखते देखते समय बीत जाता है पता ही नहीं चलता
Wow, this is very loud. I'm having trouble here.
Christy, can you ask admin to mute him? Anurag Kashyap.
I think it's okay now. Yeah, it's good. Okay, so of course patients don't really feel eye pressure unless it's very, very high. So clearly, this emphasis on IOP is being conveyed by their doctors. The doctors emphasize IOP, and this ends up leading to patients fixating on the eye pressure level and making it even more important to them than other parameters. So pre-millennial glaucoma care, glaucoma was diagnosed, IOP goal determined, treatment is advanced, and the IOP goal is achieved. There's one major thing missing here, and that is, what about the safety of therapy? Say you set a goal of pressure of 15 for a patient, and the pressure is 17. If the next step is another eye drop or laser, will that weigh in differently than if the next step is a trabeculectomy or a drainage device implant, or if or you're going to have to start Diamox or do cyclodestruction? Clearly, the side effects of the treatment, the safety of the treatment, has to play a role in decision making. It's not solely about reaching a pressure goal. And to me, in many ways, the millennial glaucoma care was a response to the fact that the prior generation, at least in the teaching of glaucoma care, ignored the concept of safety. Now, in clinical practice, all good glaucoma doctors weigh efficacy and safety. But when we were teaching glaucoma, and many of my colleagues were teaching glaucoma in that era, they would say, the way I treat glaucoma is I look at the patient, I see what pressure they need, and then I treat them till they get to that pressure. And of course, that whole concept says nothing about the safety of treatment. And so this, I think, was a mistake. And I think one of the reasons there was pushback was because overall, in most industrialized countries for sure, and probably globally, most patients who have glaucoma are not destined for blindness. And so safety has to play a role. You have to keep in mind that even though in academic institutions, we see a disproportionately large number of patients with severe disease, in the big picture, glaucoma isn't always blinding. In the United States, 25 to 50% of people who have glaucoma are aware that they have the disease. This is based on prevalence surveys. I know similar studies have been done in India and sub-Saharan Africa. The numbers are different in other parts of the world, but there's no part of the world where more than half of the people with glaucoma are aware that they have the disease. And of those aware, many are not under care, and many under care are often non-compliant. So I think you can make a case that there's probably no place in the world where more than 20% of patients are people who have glaucoma are getting appropriate care for their glaucoma based on guidelines. Yet, there's great variability in the natural history of the disease, and very few, a small percentage, are going blind from the disease. Now, the key word here is percentage. The absolute numbers of people going blind is very high because glaucoma is a common disease. And when you get up in the 70s and 80s, you have 5 to 10% rates of glaucoma in most parts of the world. In African-derived countries, it's even higher. And so the absolute numbers of people blind is very high, but the proportion is quite low if you look at the denominator. And we know that lowering IOP reduces but does not eliminate risk. So another way to look at this is, in my community, if there are 20 patients with glaucoma that may or may not know they have the disease, or 20 people living in the area who have, of these, they represent the ones with higher risk of blindness as being red. If half are aware they have the disease and half of those are under appropriate care, you might say, well, only 5 are getting appropriate care. The other 15 are destined to do poorly. But the reality is the 15 are not destined to do poorly. Only these 3 are destined to do poorly because they have the combination of poor surveillance and high risk. And many of them will live and die without ever knowing they had glaucoma. They'll drive, they'll read, they'll do everything. And this is the big picture. Patients who present with mild disease are treated very differently than patients who present with advanced disease, and they have very different risk. Now, Bal Chauhan in Nova Scotia has done some work along with his colleagues in a predominantly white Caucasian population, looking at real-world visual field change over time, followed for 7 years, and shown that there are a small percentage of fast and catastrophic progressors that lose more than 1 decibel of field a year. But if you remove those and you plot the others, And it looks very much like a normally distributed curve around zero. It looks like the noise is greater than the signal. There's some getting a little better, some getting a little worse. And this includes all the patients who are non-compliant, lost to follow-up, everything else. It's really, and with poor follow-up between visits, this is real-world glaucoma practice. Most people are not doing badly. Even in the trials, this is courtesy of Anders Hale, what you see is that the progression rates in the untreated arms of studies where patients get no treatment at all, it varies, and in fact, a large proportion of patients in the collaborative normal tension glaucoma study, as well as the EMGT, show no change over time. In fact, if you in EMGT, if you remove the effect of remove the patients with exfoliation syndrome within the dark, if you look at everybody else, it's surprising how little progression there is in patients who were untreated during the course of the study. This is a nice slide actually from my friend Ravi Thomas, who many of you probably remember from his days in India. Ravi, this was during his time in India that he had worked with a statistician to show that in the Aegis predictive analysis, which showed that if your pressure was low early on, you did better than if your pressure was high early on, greater than 17.5 versus less than 14 on the first 3 visits before 24 months in Aegis. The lower pressure predicted better outcomes than higher pressure. Ravi, showed us that this was only when you had when you inflated or stretched the y-axis. If you plot the entire y-axis with the Aegis score, you see a different story. And I think this slide on the right really shows the real truth about glaucoma, and that in most patients, it progresses very slowly. And even if you look at averages of populations, nothing is happening very fast in most patients. Now, there are subsets of patients who have very severe disease, excuse me, and do very badly, but this is a small number compared to the overall population of those with glaucoma. This is work from Ted Garway Heath from the UK glaucoma treatment study in the left, where the group that got placebo in their trial versus latanoprost, 2/3 showed no change over the 2-year course of the study. An EMGT here, if you look over 7 years, 1/3 of patients who got no treatment showed no change. And it's interesting, this 33% is actually larger than the difference between the control and the treatment group. So the effect of treatment, the benefit of treatment was smaller, probably about half the size as the likelihood of having no change if you're untreated. Saunders and colleagues have also shown in their modeling that only about 10% of patients, again, these are mostly Caucasian and Asian populations, or that are looked at in the African derived patients have much higher rates of progression of vision loss. But over a lifetime, only about 4% that will go blind based on their modeling, about 10% will have visual impairment. And so even over 50 years, most patients do pretty well. There's a lot more glaucoma light than there is bad glaucoma. And I think this is what has led to this MIGS revolution, or the millennial approach, which is this emphasis not on IOP lowering, but on patient, patient acceptance of treatment, which we don't want the treatment to be worse than the disease. And prior to this, often it was. So what is glaucoma surgery for low-risk glaucoma? For the many who don't have high-risk glaucoma, cataract surgery itself is a good IOP lowering procedure, angle-based MIGS. There's more data needed on some of these goniotomy procedures that have not been studied in the prospective randomized trials that have compared the devices with phaco versus phaco alone. Whereas some of these procedures where you slice open the trabecular meshwork or do something else, the goniotomy procedures, they haven't undergone the same level of study. But the thing is that people still use these procedures, and much of this is reimbursement driven in different regions of the world, how easy it is and how much people get paid to do it. Because with mild glaucoma, as my friend Don Minkler says, if you treat low risk glaucoma, or if you treat non-glaucoma, everything seems to work. And so because most of the patients are destined to since most patients are destined to do well rather than poorly, these procedures apparently seem to work, even though some of them may have not been studied. And some of them, it's possible, may over time do harm. Because if you do damage the meshwork, it's possible that when scarring does occur, the pressure will actually increase, although that hasn't been proven. I really do think we need more prospective studies on some of these standalone adult goniotomy procedures, and hopefully that data will come. Of course, you want to supplement with IOP lowering medicines and when possible. And IOP lowering medicines are not always available and affordable. I'm actually very happy that in India, the pharmaceutical industry has has done so much to bring low-cost medicines available to the masses, and this is just not possible in many other parts of the world. So this is a schematic, sort of summarize what I've spoken about right now, pointing out that this is Anurag Srivastava, was one of my fellows, is now actually is one of the deans at Albert Einstein College of Medicine. Anurag and I came up with a schematic. It's very basic. Basically, on the x-axis, we have the risk of functional vision loss, and the y-axis is relative importance. And basically, the boomers, my generation, had this emphasis on IOP lowering and placed less of an emphasis, at least in the teaching, on the risks of therapy. And this was perhaps related to this generation, really reflecting the influence of academic glaucoma practice, where you saw the worst patients with the most severe disease. If someone has bad glaucoma, they've gone blind in one eye, then those patients, you'll be willing to try acetazolamide or do a trabeculectomy or tube implant or get the pressure down really low, certainly below 12 and sometimes even lower. And you'll take those risks. On the other end of the spectrum, in patients with low risk of functional vision loss, the risks of therapy are more important than the amount of IOP lowering. Most of these patients are going to do well, so you should not be emphasizing maximal IOP lowering. You don't need to get to 12 in patients with low risk glaucoma. And the millennials have focused here, and of course the pendulum swings back and forth. Obviously, the savvy glaucoma practitioners will look at each patient individually. But there are eras of time when there's trends related that lead to over-treatment versus under-treatment of the disease based on what's new and seems to be hot. And in recent years, the focus has been on lower risk, perhaps less effective glaucoma surgeries that can often be combined with cataract surgery. And this is where the growth is occurring. This is unlike the prior generation, where the emphasis was on maximal IOP lowering. The reason I think both will have to coexist is we are going to see, and this is US data, many, many more patients that are older that will need very low intraocular pressure. So even though I do think that the MIGS era is here to stay, and that we will continue to do that type of surgery for low risk disease, and most glaucoma patients would do well, as people live longer, we're going to see patients in their 80s and 90s do quite poorly unless they have aggressive IOP lowering. And so we still need to keep the heavy guns available, such as trabs and tubes, to get those pressures really low. We're going to see about a 4-fold increase in the number of patients over the age of 90 with glaucoma, representing the overall, this is the overall proportion of patients with glaucoma in that group. And over the age of 90, we're going to see many, many more. And I think for those patients, you're going to still need to do trabeculectomy. Now, I'll make a few comments about trabeculectomy and show you my surgical approach. Now, most of the world has followed the lead of Sir Peng Kaw, who has been a strong proponent of fornix-based trabeculectomy. And I also perform fornix-based trabeculectomy in a subset of patients, but my preferred approach is limbus-based trabeculectomy in eyes that have good exposure. Now, Peng, Peng's a good friend, and when he did his work at Moorfields to convert from limbus to fornix-based trabeculectomy, he made 2 changes. He changed the incision location, of course, limbo-based or fornix incision to a limbal incision, but he also started to apply antifibrotics to a much broader area of conjunctiva. And to me, that was a more critical step, because applying mitomycin or 5-FU to very small focal areas was giving these small focal avascular blebs with a ring of steel. And these blebs cause problems. And the broader application of mitomycin in lower doses, I think, gave us more predictable blebs, whether you did fornix or limbus-based surgery. So frankly, I don't think it matters that much what you do. I prefer the limbus-based approach because, we have 3 fellows a year, and the fellows usually leave our fellowship. We have 12 glaucoma doctors that they get exposure from, including 10 full-time at Stanford. And most of them do fornix-based surgery. So I'm one of the few that do limbus-based. Actually, it's about 70-30. Most are doing fornix-based. This is my limbus-based technique. It's not a new technique. Many would look at this as a technique that they used to do before they switched to fornix surgery. But the reason I like this technique is that if you pay attention to limbo-based trabeculectomy, you get watertight closure, and you have a lot of ability to manipulate the eye in the early postoperative period to titrate pressures to wherever you want to get them. Now, trabeculectomy is a highly titratable procedure. You can do a trabeculectomy and aim for a pressure in the mid-teens, low teens, or even single digits based on how aggressively you remove sutures, how much antifibrotic you give. And to me, as someone who believes in individualized care being so important and not this average approach where you just set a pressure goal and go for it based on population averages, I think having this titratability is very, very important. There are many, I'm not just a few, many patients these days where I'm actually aiming for pressures of 6 to 8. Now, we don't always get there, but there are people going blind with pressures of 10 to 15 all the time in my practice. So many of them are older age patients, and they just need lower pressures off of medicines, and that's their only hope. Now, again, this is proportionately a very, very small proportion of the overall number of people with glaucoma. But the absolute numbers are adding up, and they'll get bigger. This is mitomycin being applied. I use a semicircular flap. It doesn't really matter. You can use a trapezoidal flap or a rectangular flap. It doesn't matter what your flap looks like. I use semicircular because the opening in the eye is going to be semicircular with the punch. This is not a highly edited, fast, speeded up video at all. This is not this is kind of the procedure, and trabeculectomy is really just a 15 or 20 minute procedure, even when you do it with the limbus-based approach, as long as you have a good assistant helping you hold the conjunctiva out of the way. It could be a fellow or a surgical assistant. I usually use a couple of stitches. I don't think it's that important to know the exact pressure at this time, other than the eye should be well formed. I tend to aim for about 15 to 20 for the first postoperative day. I don't like to aim for really low pressures early because I routinely will remove stitches in 1 to 2 weeks after surgery to get to titrate the lower pressure. This is a running horizontal mattress closure using a blood vessel needle, which doesn't leave holes in the conj. It's not always this quick. Sometimes it takes 2-3 minutes. But if the conj is mobile and you have good exposure, it can take 30 seconds. The good thing about this approach is that the suture will bury. So as you can see along the incision line, you don't see any suture, it's buried. You just have the suture on the two ends where the knots are. This does give a watertight seal so that if 1 day after surgery, you, for whatever reason, you want to massage the eye or which we often do, or remove a suture if the pressure is very high, you can do it. If you want to inject 5FU early on, you can do it, not worry about leaks at the limbus. Fornix-based trabs are also watertight sometimes, but sometimes they have micro leaks at the limbus, and I think micro leaks early on after surgery when you make a limbal incision are a common reason for getting suboptimal long-term trabeculectomy results. And as you can see towards the end of that video, I'll just show that again. I don't leave the case unless I see a trap, unless I see a bleb. I don't think you should go. Okay, maybe it's not worth doing this again. Yeah, so you definitely want to see the bleb come up because you don't want to. If there's no flow, you need to go back in and open up again. This is, our blebs look typically like this, but minimal vascularity. I try to titrate the vascularity with postoperative 5FU, giving the 5FU closer to the bleb, and not 6 clock hours away, but rather maybe 2 or 3 clock hours away, and ballooning the conch near the bleb site. And we get good results. I mean, we probably get better results than the average. Our fellows are pretty happy with what they see, and they go out there and become proponents of this type of approach. It's not always possible to use this approach, and especially in patients of East Asian descent, people, Chinese and Japanese background. Sometimes we aren't able to get the exposure to make that initial incision 8, 9, 10 millimeters from the limbus. You really need posterior entry with that approach. Otherwise, you get these ring of steel focal blebs that do give suboptimal IOP lowering. So this is probably 80% of my cases are using this approach and 20% using the fornix-based approach. We did a randomized clinical trial comparing 5-FU and mitomycin, which in those days was to see which of these drugs we should use, but nowadays gives us an idea of what the data is with mitomycin, because very few people are doing mitomycin trap studies these days because it's kind of old news. When we did this work back in the 90s, people were saying, well, why are you doing such a trial? People won't be using these procedures in 5 years. We'll be doing something else. Well, 25 years later, we're still doing mito trabs. And these are the results from the initial work at 3 years. About slightly over half of the patients had pressures under 12 with 5-FU, which did better than, with mitomycin, which did better than 5-FU. And this trial, really was a trial that was a model for other trials like the TVT study and others, where you have this multi-center collaboration of people, which gives you generalizability when there are people using different techniques. But there are pros and cons of having these like imperfectly standardized procedures where people are allowed to have some variability in how they do things. So we did let people do the trabs any way they wanted to do them in that study, Limbus or fornix. It wasn't didn't have to be one way or the other. Now here is some data from TVT. Just want to check the time here. I think we seem to be doing okay. All right, so it's showing that you get very low pressures with trabs and tubes. These are eyes that have had prior surgery, prior incisional surgery. But even in the primary TVT study, the trab group and tube group both do very well, with the trab group, I think, doing a little bit better at 3 years in terms of IOP lowering and less dependence on medications. Here's a work that I think has been underappreciated. This is work from Joe Caprioli's group, showing that trab can actually improve visual function. And I see this a fair amount in my clinical practice. Practicing in Silicon Valley, we have a lot of highly intelligent patients who also have a lot of resources. And some of them opt at their own choice to do visual field tests every 6 weeks. And you might say, that's crazy how often that is. But some patients with moderate to severe disease in our area, where especially those where we're holding off on treating aggressively with surgery and have vision loss closer to fixation, many of them opt to do very, very frequent fields to then know when the optimal time is to do surgery. And so I've been able to gather a lot of data on patients, and I'm convinced without any doubt that trabeculectomy, when timed properly and with very low pressure goals, can improve visual function. But I haven't published our work. Joe Caprioli has been much more scientific and using point progression analysis. He has shown that if you lower pressure dramatically and the amount of pressure lowering correlates with the degree of improvement, you will see visual function improvement with trabeculectomy, and it's long-standing. And this is somewhat ignored work that I think is important. I definitely believe that, especially in patients progressing rapidly, if you do a trabeculectomy, get them down to 6 to 8. I've seen patients with visual function improve, their visual acuity even improve. And this is not acute glaucoma. I'm talking about patients with chronic primary open-angle glaucoma. And Spaeth has been talking about this for years. Now, it doesn't happen a lot. It's not like, you should be telling patients your visual function will improve after I do a trabeculectomy. It's not a common phenomenon. But what's more common is that they appear to stabilize. And we know that over time, glaucoma progresses. So that we're losing 5 to 10,000 retinal ganglion cells every year. So if you do show stability for 5, 10, 20 years, it probably means that you rescued some cells that were dying by lowering the IOP dramatically, because you should otherwise be seeing change. It should be worsening. So some of these patients who look stable may in fact have had some degree of improvement, which is then confounded by the worsening that we expect with aging. I'll say a few words about PreserFlow. This is a device, it's a SIBS device that's been highly anticipated. It's available in parts of the world. I show this here to highlight the fact that I think the PreserFlow is a good device. It's not FDA approved yet. Hopefully it will be someday, but also to point out that trabeculectomy still does better. This is a head-to-head randomized clinical trial. comparing trabeculectomy with the PreserFlow. This type of study has not been done with any other of these blood-forming device procedures, which have been marketed without this type of prospective data that was, at the highest level that was part of an FDA trial. But it shows you that trabeculectomy beats the microshunt by 3 millimeters, and also you have a greater proportion of patients reaching pressure goals with the trabeculectomy. And more medication free in 1 year with trabeculectomy, about twofold difference, although most patients didn't need medicines, 0.3 meds in the TRAB group, 0.6 in PreserFlow. So PreserFlow did pretty well, but not as good as TRAB. But I do think the advantage of PreserFlow is there are fewer blood leaks and less hypotony. So there are patients, especially high myopes, where you worry about hypotony maculopathy, patients who've lost vision in one eye from trabeculectomy and won't allow you to do it in the other eye. PreserFlow is not going to, on average, give you quite as low pressure as trabeculectomy, but there's a place for it because there are certainly patients that have high pressures that don't need single-digit pressures, that would do very well in the 10 to 15 range, and safety is more important. So even within the blood-forming space, safety and efficacy have to be weighed, and I think PreserFlow will have its place once it's approved, hopefully approved in the US, and it's already making a difference in some other regions of the world. Switch gears to the final part of my lecture, and hope to wrap up in the next 5 to 8 minutes. This is the science of the patient perspective that we've been funded to do by the FDA. I showed you some patient preference work, but I'll now say just something about the patient-reported outcome tools that we're developing now. Historically, and in many communities, in all parts of the world, the doctors make the decisions for the patients. The doctor tells the patient what they need. The patient says, "Okay, let's do it." But increasingly, we're finding patients, with the power of the internet and getting more involved in their own care and really being partners in the decision-making process. I see this a lot in Silicon Valley, where the average glaucoma patient is more intelligent and certainly much wealthier than the average glaucoma doctor. The patients play an important role in decision making, and also patients, want to tell you how they did. And the Food and Drug Administration is very interested in finding out what, ultimately the goal of any regulatory agency is to serve the public and make sure the patients who receive products are getting good products. And so you have to hear from the patient, and this is an increasingly important initiative in the FDA in all arenas. And so I was involved during my term as AGS president. I co-organized a workshop with Malvina Edelman. We published the results of this workshop to support safe and effective minimally invasive glaucoma surgery here. Some of the people who attended, this is my Malvina, who runs the FDA section, FDA device section. George Spaeth here, Rich Parrish, a few people you may recognize here. So from this work, FDA decided, and this is unusual, decided to fund the development of a patient-reported outcome tool for glaucoma surgery. And so they supported us, and I served as principal investigator along with Malvina. This is an ongoing project where we conducted physician and patient focus groups to develop a web-based questionnaire to ask patients to really assess the impact of glaucoma surgery on patients. This is a long process, as I found out. We developed this tool in 2018. We refined it over the next year with interviews of subjects. And then we are now doing a field test of 500 to 700 subjects at 15 to 20 sites who are undergoing MIG surgery. We were slowed by the pandemic. This should have been completed this year, but but we're still enrolling patients. And we're going to develop actually the final deliverable is a web-based questionnaire that can be used to assess how patients, what impact novel glaucoma surgeries have on them. This is the reason the FDA is interested in this is once this tool is developed, companies can use this tool as part of their submissions to show that whatever procedure they're trying to get approved actually helps patients. This is an important part of the approval process. But people will, of course, this will be available in the public domain with no cost. So if you're doing studies in India, you'll be able to access this tool, and maybe I think people will probably modify the tool based on different regions. But it will serve as a way to capture the patient's voice in trials. So a few summary points. Glaucoma surgery in the 2020s. I expect continued growth of MIGS because most patients with glaucoma are not destined to do poorly. Minimally invasive options are a good approach. They help decrease the dependence on medicines. But I think there'll be increasing numbers of older patients with bad glaucoma. The proportions will be low, but the absolute numbers will be high, and more will need trabeculectomy. I think a patient-focused approach will emerge where hopefully doctors will not be at meetings saying, I do this because this is what I know how to do and this is what I get paid for, but rather talk about what each patient needs. And I also think for advanced disease, we'll be aiming for single-digit pressures in small subsets of patients going forward. I'm fortunate enough, and we've actually since added 2 more glaucoma colleagues to our team, and to work with a nice group. This is our Stanford ophthalmology glaucoma team, and Robert Chang in particular is a master MIG surgeon, and we share patients amongst each other. You know, we send patients. So when a patient comes to see me, I will try to never say that you need this because this is what I do. The first thing I want to do is find out what I think the patient needs based on all of the options that are available out there, and then find out which one of my colleagues is the best to do that procedure. And so we send patients back and forth amongst each other based on, because there's so many different options in glaucoma now. No one can master all of them. And some of them are very similar, so it's okay not to know every single one of them. But imagine going to a cardiologist with one of your parents and saying, what does my father need? And the doctor's saying, well, I do angioplasty, so they need angioplasty. And so, you would say, well, that's not how. If they need a bypass, the person has to send the patient to the cardiac surgeon. And unfortunately, this is what's happening in glaucoma. Doctors are doing what they know how to do, and sometimes there isn't data supporting what they know how to do for a particular patient, but they do it anyway. And oftentimes they get away with it because, as most patients are going to do well, it maybe doesn't matter. But it's not the right approach, and certainly not the right approach to teach. And one of the things I worry about is glaucoma fellowship procedures during fellowship trabeculectomy has decreased in numbers during fellowship from 49 to 32 over a 5-year period, whereas tubes have stayed stable and the angle procedures have increased. And this is as a primary surgeon, not as an observer. But I think we have to keep trabeculectomy alive because I think there will still be that subset of patients that needs it. So to summarize, most glaucoma patients do well, small proportion destined to do poorly, but their absolute numbers are large. Average results of trials can be misleading. The baby boomers were focused on IOP lowering. The millennials have been focused more on safety. And again, these are not age groups, but a way of thinking. And then I'll just point out that I think it's still important for all glaucoma doctors to learn how to do a good trabeculectomy and put in the effort perioperatively to try to get good results. It's not okay to just do the surgery and say, come back and see me in a month. Thank you very much. I think we maybe have a few minutes for questions. I'll turn it back over. I see Harsh over there. And Vanitha, the reason we're a little late is because you were overly generous in your introduction for me. It was
not at all. But
otherwise
I have to compliment you because you did say at the very outset there's going to be philosophical, it's going to be thought-provoking, and it was all of that and more. So thank you very much. It does give us a big picture, in a country where options are limited and we don't have as many options as you do out there. And money is a very major factor. I'm sure Dr. Pradeep and Dr. Harsh have a few words to say on that.
Okay, thank you, Kuldev. And I must say I'm really proud of you because I think maybe when you grow beyond a particular stature, I think you start realizing that the basics were perhaps at times better. Because Keith Barton said exactly what you did, that the trabeculectomy must not die in spite of all the newer innovations that you're having. And I really feel happy that you are bringing on these things. And I think you are at the right place who can challenge these things. And my worries are that the insurance companies are pushing too many things too fast, and we are falling a trap to it. And I guess a person like you is in the right place to challenge them and tell them to please go slow for what actually the patients need. And I think you so beautifully enlightened us that yes, it's a glaucoma is a medicine which has to be individualized. So it has to be individualized to the patient and to the doctor as well. Like Vanita rightly said, we have people in the country and thousands of our doctors may not have the very basic training. And we put out a study and we tell them, no, to do a combined is better. Now that guy has done only one trab in 1 year. And if you want them to do a combined surgery, you can understand what will be their fate of the patient. So
Yeah.
we have to individualize it. Yeah, you're saying something, Kuldeep? Yeah.
No. I'm saying you're absolutely right. I think, if Anders Hale, who I think is one of the most brilliant minds in glaucoma, and besides, perfecting perimetry, he's earlier this year, I had the honor of giving the Edmund Spaeth Oration at Philadelphia College, which is named after George Spaeth's father. And Anders joined us as one of the discussants. And this is available on YouTube, but they haven't made it public yet. So if you have a way to reach your residents, I may send you the link. Because if don't watch my talk, it's not worth it. You probably heard it here anyway. But if you go to 58 minutes, Anders gives a 5-minute summary of why we should not look at averages in patients. And he shows us trial data and shows that, so much of what we do has been guided by averages from trials, but there's so much variability. And what you said is so true, that we have to individualize care. We cannot look at averages because average, I mean, if you look at the average shoe size of a male in Hyderabad as being 7, I guess that's U.S. shoe size, and maybe I don't know what it would be in Europe in there, but maybe another number. But if you bought 10,000 pairs of shoes and said, hey, average size is 7, here, distribute these shoes, the shoes would fit almost nobody, right? Because the average tells you so little about individuals. And in fact, unfortunately, that we've been treating patients, the trials led people to treat based on averages, and the individualized care is very critical. So I'll send Santosh this link, and don't hear my talk. Go right to like 58 minutes where Anders speaks, and you get 5 minutes of like the best glaucoma lecture in 5 minutes you'll ever hear in your life.
Yeah. So actually, exactly. Like they are telling us that only 50 to 60% of the patients are adhering to their medicines. Now, if that is happening, then you want to tell us that 40% are going bad? They are not. That means, are we over-treating everybody else?
Yeah.
So that's good.
Yeah, no, and this is a lecture I haven't put together yet because I've been thinking about it for 5 years, because there are 4 scenarios, right, that can happen. So either you're compliant or non-compliant, and either you should be treated or not be treated. So if you create a 2x2 table, I think about 25%, at least in North America, probably 25% fall into each of those 4 tables. 25% of people are compliant and they need it, and 25% are compliant and they don't need it. 25% are non-compliant and they don't need it. 25% are non-compliant and they need it. If you look at the numbers, and so so it's not that everybody who's non-compliant is making a mistake. In fact, some of these people who are non-compliant, if you just look at the sheer odds, are not progressing and not doing badly because they don't have glaucoma. In the trials over and over again, and these are trials with very rigid entry criteria, 1/3 to half of patients don't show progression with no treatment or placebo treatment over 5 years, 8 years, 10 years. And so, if nothing changes in 10 years, that's not glaucoma, untreated, no change in 10 years. And so clearly, this is why non-compliance is not, I personally think non-compliance is less of a problem than lack of surveillance. Because whether you treat someone or not, it's over time you will find out if they have glaucoma or not. So the goal, really, the most important parameter is, of course, to follow the patient carefully. Whether they take the treatment or not that you initially prescribed is secondary, assuming they actually are coming in for the regular appointments. Of course, if they don't come back and they happen to need the treatment and they're not taking it, that's a tragedy. But if they come in regularly and they're non-compliant and they're not getting worse, then that's fine. They should continue to be non-compliant. But if they are getting worse, you can offer surgery. You can do other things. So really, surveillance is the elephant in the room. But people don't talk about surveillance because pharmaceutical companies and other stakeholders don't make money. Even glaucoma doctors don't want all their patients to come back on every visit. We don't have any room for them. We're overwhelmed by the sheer numbers of patients. So no one is calling saying you missed your appointment. But the compliance has got a lot of special interests involved because the companies, make more money when people are compliant. That's why all these educational stuff is focused on non-compliance, when in reality, the real issue is surveillance and finding a way to do this without the patient actually coming into your office. If you can do it remotely, use telemedicine, find ways where you can keep in touch with people and find the subset that are destined to do poorly, get them in and focus your energy on them. And then the others you follow at appropriate intervals. I think, and that's our challenge. The next generation, hopefully some of whom are watching, will hopefully solve these issues. And I think they're definitely solvable, definitely doable.
Pradeep, please go ahead.
Thank you, Professor Kuldev. It was really a wonderful talk. And, demographically and thinking wise, I am a non-millennial person. And so that's why I liked your talk very much. And particularly, you have not only that given a full credit to the trabeculectomy, but also you said that the limbal-based flap also is there to survive. And many of us are still practicing the limbal-based flap, and we are very happy with that. And there are so many advantages of making the limbal-based flap. So there is always a bandwagon, and everyone follows that without knowing the pluses and the minuses of that. So that was fantastic. And the other point which you brought out is that the benefit of the treatment is smaller, at least in the early manifest glaucoma trial, than the benefit of the no treatment. So that is very important. And the other thing is that the 90% of our resources are used for those 10% who are diagnosed to have a glaucoma and who are not likely to progress. And hardly the 10% of the resources are used for those 90% patients who are not yet diagnosed to have a glaucoma.
Yeah. And this is the problem. And this is, I think, very much related to the economics of glaucoma, because it's about access, right? India is if you look at averages, in some ways is a poor country, but it's also a very rich country, right? Because there's subsets of the population that have incredible resources and can get the highest quality care and pay top, rupee for it. And so this is a problem in the US also. People who have good access to care. There's a joke I have, is that anyone with good health insurance is a glaucoma suspect until proven otherwise. And because the reason for this is if you see people who come in with a corneal abrasion, if you do enough tests on them, they'll all leave your office with this glaucoma diagnosis or glaucoma suspect diagnosis, because certainly an OCT will have some area where it's a little bit red, or there'll be some slight asymmetry in the optic nerve, or something that will lead you. And what happens is these people then end up being followed, and a tremendous amount of resources being used for these patients over their lifetime because they have good health insurance and access, and they're important. Whereas there are all these other people who don't even know they have glaucoma, and a subset of which are going to be doing very poorly. And you said it perfectly, Pradeep. The resources have to be shifted to find those people, and we shouldn't focus on these patients who have low risk. And unfortunately, we do that because some of them have resources. They're afraid of glaucoma. You tell them you might have glaucoma, they'll be scared and come in, for the rest of their life. And so anyway, this is something we could go on and on talking about. It's just an absolute honor for me to get together with my friends who I see and also have a chance to reach a broad audience. And I will send the Space Oration YouTube link, which I hope someday they make public. But until it's public, you can still access it if you just click on YouTube, and please look at Anders's talk, because I think it's a brilliant 5 minutes of summarizing what he gained from the trials, not to mention his expertise on perimetry. So I'll send that to Santosh, and I think we're at time. I mean, it's late in the evening there, right? And it's, what is it, 9 p.m. or?
Yes.
Yeah, it's 9 p.m.
Yeah, so it's got to be dinner time somewhere.
So thank you very much, Professor Kuldev. Very well said, I would say, but I'm sure there's the other side of the coin too. Not just with regards to procedures, but also with regards to patients, because we have, for some patients, getting a second and a third and a fifth opinion just confuses them no end, and they end up with absolutely doing, being paralyzed in terms of making a decision. And those are the ones that I worry about, because you would be aware that the majority of the glaucoma that is diagnosed in the country, once patients access healthcare, is when they have actually lost vision or close to losing vision in one eye. So it's a tragedy. There is absolutely no doubt about that. The quest to keep serving these kind of people, and these and also in the underserved areas, just goes on, I suppose.
But I think the next generation, the Generation Z, is going to solve these problems because we can use technology,
AI,
and I think I'm really excited about some of the ideas I'm seeing. I mean, obviously, there'll still be needs for old guys like us, old people like us to do the trabeculectomy when no one else is left to do it. But hopefully we can train people, the next generation, to do everything, all the procedures, but also just develop better ways to find people that need care and just to provide access to people, out there that are not getting it. And this is really not only in developing countries. This is the most industrialized countries in the world have this problem also. It's a worldwide problem of people who need care not getting care for glaucoma. And then the other half, which is people who don't really have glaucoma getting way too much care, which is going on, as Pradeep said, at the same time.
Well, I did read your editorial, trabeculectomy must survive, and a simile, as sublime as the Burgundy wine, was something that stuck. Yeah, there's a lot of debate in one of our groups about it, but it was all very healthy.
Yeah. Well, the great thing is once you get to be my age and you've lost all your hair and it doesn't matter, people don't care when you retire or stay on. You can pretty much say anything and write anything, and it's nice to have that be at that stage, of one's career where you can get away with giving philosophical talks without showing something new, but rather just reorganizing what people already know to have them maybe look at it slightly different.
Yeah. Well, thanks very much. That was really enlightening, and we thoroughly enjoyed ourselves. I mean, it was, presenting a perspective that we should not be losing at all. And going forward, should, keep that very much as, a target, not as IOP, but a target for each individual patient to customize or tailor-make their treatment.
Thank you, Vinitha. I see Santosh there as well. Santosh, thank you for reaching out, and it's just been a pleasure. And I hope the next time we communicate, it'll be in person somewhere, because I miss seeing my friends in India, and hopefully we'll have a chance in the not too distant. This thing hopefully will be over soon. Yeah.
Thank you.
Okay, thanks. Have a great evening and weekend.
Yes.
And thanks. Thank you for the honor.
You have a good day.